Thank you. Thanks for that introduction. Good morning still, everybody. This is my first CML Horizons conference, and I'm really delighted to be here to speak to you about sex, self-esteem, and a chronic disease. So I just wanted to start with a couple of definitions. Sex is part of sexuality, and this is quite a complex concept. It's a means by which personality is expressed, love is communicated, and emotions are experienced. And there are three key components here. We have a biological component where we're talking about capacity to give and receive pleasure, so sexual functioning, human sexual response, desire, excitation, and orgasm. We've also got a psychological component. So here we speak about sexual self-image, and this also talks about body image, the image we have of ourselves, our appearance. And there's also a social component, so social gender role, who we are, and how we as women and men interact with others. On the other hand, self-esteem is the degree to which the qualities contained in our self-concept are seen to be positive. And this reflects a person's image of oneself and their accomplishments. And other terms that we would use are things like dignity, confidence, morale, self-respect, self-worth, and self-trust. So these are really two concepts that are quite subjective. So why are these topics so important in CML? Well, we've seen about average age at diagnosis, earlier 65 to 67 years. But CML can affect all ages. And we're talking about, patients who have got lives, families, who are sexually active, who are fully functional. We've got increased survival rates. So from the 1980s, 23%, now we're looking at 80% and plus. So the number of people living with the disease has doubled since 2001. And now the suggested goal of treatment is quality of life as close as possible to that of non-leukemic individuals. But what does this actually mean? We've got more than 60% of patients who face lifelong treatment at this time. Adverse events are reported in over 50% of patients, and although we've seen that these may not be severe adverse events, these are adverse events that can have an effect on daily life, function, and also quality of life. This has a particular impact on younger CML patients, so between 18 and 59 years of age, and has some major impairments in social and role functioning. So I wanted to share this study with you. This is Phillips in 2013. It's only 62 patients, but it talks about quality of life in patients who were treated with TKIs. And these are patients who've got an average of 4 years on TKIs. And they were asked to look at symptoms and what level of distress this actually caused. And I just wanted to, even though you can see with the TKI distress mean, this went from a range of 0 to 4. So the levels may seem to be low, but these are persistent problems. We're talking 4 years of therapy. We've got impact on function. So patients feeling drowsy, having pain, having difficulty concentrating. We have impact on appearance. So changes in skin have been noted. I don't look like myself. Swelling of arms or legs, hair loss, weight loss. An impact on sexual intimacy. So things like dry mouth. I mean, how easy is it to kiss somebody and express intimacy in this way if somebody has a dry mouth? Shortness of breath, sweats, numbness and tingling in hands and fingers, so even sensibility. Obviously problems with sexual interest or activity, mouth sores, and then some other side effects that were noted, an impact on quality of life that can have an impact on socializing, things like nausea, itching, vomiting, and difficulty swallowing. So it's really important to identify and try to address these causes for patients. Due to time, I'm not going to go through all of these. This has been a paper, the information that's been adapted. So these are the types of information that maybe patient advocates could give to help patients manage side effects, because this is really important. And as Gail said before, we're talking here about promoting self-esteem, taking care of side effects and symptoms that patients are experiencing. One of the important ones is fatigue, and one of the studies that was about just over 400 patients taking imatinib reported that chronic fatigue was a real factor limiting health-related quality of life. And this wasn't just physical, but also mental health, and the limitations that this had in work and activities in terms of time and performance. Higher fatigue levels in certain patients had problems with their jobs themselves. So, when we've got fatigue, does this mean that you can actually do what you want to do? Is this an impact on your social life, your work, your routine? Have you got to think about lifestyle changes? And can you actually be who you want to be? Can you be that active parent? Can you be that active partner? So what advice can we give? And I'm talking also about patient groups. We can promote patients with a good diet, making sure that they're eating well. This may include keeping a diary to identify the types of foods that they're eating, encourage about drinking plenty of fluids, making sure that patients get exercise, so encouraging people to set some goals, to plan exercise into their day, maybe doing some light exercise, so things like walking, yoga, some Tai Chi, if anybody made it the other morning. Making sure that people are actually staying active as well. Sleep is really important in managing fatigue, and again, encouraging exercise can turn that back to making somebody physically tired as well as mentally tired, to encourage a good night's sleep. Getting into a routine, keeping the bedroom for sleeping, so not dozing on the couch. If somebody is tired and needs to go to sleep, get into the bedroom. Ensuring that the bedroom, where they're going to sleep, is a room where there's no noise, that the temperature of the room is adequate. Maybe eating a snack, having warm drinks, avoiding alcohol can all help with sleep. And if patients can't sleep, they need to get out of bed. There's no point in tossing and turning. Other strategies for helping with fatigue can be things like relaxation or complementary therapies. So moving on to self-esteem. Self-esteem is the image that one has of oneself, and this is really important about one's skills, one's qualities, and also one's accomplishments. So we think about role, about self-determination, and this links in really well with what Gail said earlier about self-efficacy. So self-efficacy is a belief in one's capabilities to organise and execute courses of action required to manage prospective situations. Now, what does this actually mean for CML patients? We've seen these new self-management issues. We've got side effects of disease, side effects of the management, medications. We had a fantastic presentation yesterday by Dr. Friedank, who spoke about the rules and regulations behind drugs that need to be taken. So take it with food, don't take it with food, what type of food are you eating? So the whole concept is, we have patients who are effective in their own lives. Now we have another added issue that people have to deal with. And how can we help patients promote self-esteem and their own confidence? So one way, I think, is encouraging patients to be proactive in their care. So I think patient groups can provide information about conferences like this, useful links, information about journals, so where they can get information from, up-to-date and high-quality information, and also clinical trials that may be of interest. I think patient groups also need to give as much information as is requested by patients, because this helps patients to have realistic expectations. And one of the things that I've really found useful is frequently asked question pages on websites. Another thing is about helping patients to problem solve. Now, this isn't that that patient groups need to problem solve for patients. More to encourage people to do this themselves. Again, this is encouraging patients to take control. So getting them to identify problems, getting it into smaller steps, discussing solutions, and what are the pros and cons. So again, get patients to share their experiences, because their experiences are really valued. We can also encourage patients to set goals. I'm not going to go through this. Specific, measurable, achievable, realistic and timely. And I have an example. So if somebody has a problem about oral medication, the specific of the goal may be adhering to oral medication. Is it measurable? Well, patients can record this. So it could be recorded in a diary, for example. How can we make this achievable? So if patients can physically take oral therapy, what can we do? Are there barriers to other reasons why they won't be able to take certain therapies? What can we help with suggestions? Do they need to change their routine until they get into a habit? For example, medication near a toothbrush, medication near the breakfast things in the morning. When do they actually need to take this? Do they need to have it in the car if somebody's always on the move? They may be home late. It needs to be realistic. So we need to also encourage patients that this is important for disease control and not skipping doses. It needs to be timely. So it's got to be, there can be timelines, set. So we can actually check with patients, how are they getting on? What are the problems that they've identified? And again, one of the things that I quite like the idea of is whether as patient groups you can get people to report on the problems that they've had and what they've actually done to overcome these, or maybe the type of thing using a blog, which could be quite useful. Promoting self-esteem and managing side effects. So tips that we can give to patients. Patients really are eyes and ears for the healthcare professionals, about knowing their own body, keeping a track of changes with a diary, for example, what's changed, so routines, treatments, dietary changes, what worked for them to do with managing side effects, and encouraging people to report these side effects or problems to the team, not just to miss doses, because there can be other strategies to manage side effects and other treatment options. Moving quickly on to sexuality and sexual dysfunction, we can't forget that sexual dysfunction is present in the general population. So it's not just something that happens to CML or patients taking TKIs. And these are a group of disorders which are characterised by physiological, psychological changes, and this can cause psychological and social distress. Causes can be the illness itself. It can be secondary effects of treatment, so things like nausea and vomiting, something like skin changes, so changes in skin texture, skin colour. It can also be emotional and psychological factors, so the diagnosis and the burden of treatment, body image and appearance issues, communication, and here I'm talking about communication between partners. So what can patient groups do to help address sexual function issues? It's a really sensitive subject, this, and helping with open discussion is really important. The right environment, a non-judgmental attitude. Questions that can be asked: has anyone talked to you about how disease or treatment can affect your ability to have sex, sexuality? Another is, do you have any sexual concerns you want to talk about? Now, this is a real Pandora's box. Once you start asking questions like this, people need to, me as a healthcare professional, you as patient advocates, we need to be prepared to deal with the responses that patients give and questions that they ask. So feeling confident to discuss these problems, and one thing about this is it's really important to have education, training, and maybe some role play about how to deal with responses from patients. Always remember that there are healthcare professionals that can help with behavioural treatments, group and couple-based therapy, and also traditional sex therapy. Dealing with sexuality and body changes, again, encouraging open discussions is really important. And here I'm talking about open discussions between partners, because it can have a real positive effect on intimacy. If intercourse for a couple is a problem, it could be agreed that this can be avoided for a while. So this just takes pressure off people. It's important to rebuild intimacy, but this can be through steps, spending time with somebody, holding hands, kissing, cuddling, caressing, moving on to intimate caressing, and then to intercourse. And of course, there's always the opportunity to refer to other healthcare professionals. So now I just wanted to speak about something that's really quite important. Another role is that of having children. Now, TKI therapy and fathering children in males, there's increasing evidence that children born to men taking imatinib at the time of conception don't have an increased risk of congenital malformations. And we've got some evidence here about this, although it's quite small. Outcomes, in 13 pregnancies, we've got outcomes for 8. So 3 abortions, 2 were therapeutic abortions, 1 spontaneous, 1 death in utero, and 4 normal pregnancies. 7 out of 8 normal pregnancies reported in another study, and 9 uneventful pregnancies in 2 other studies. There's also information that was in this Appley paper about personal communication from Novartis of over 60 pregnancies that were without associated complications or congenital abnormalities. On the other hand, dasatinib and nilotinib, we've got limited information. So one study reported outcomes for 7 out of 9 pregnancies, and these were all healthy at birth. So advice that we give to patients, there is no written guidance, unfortunately, and I would always suggest to check with the hospital. In some centres, it's suggested that no precautions are required, so it's fine to go ahead and with fathering children. Some centres also want spermograms because I think there are limited reports of low sperm volumes. On the other hand, TKI therapy in conception in women is another story. So we've got a report here by PI, which was 150 pregnancies, and these were patients of women who were exposed to imatinib during pregnancy. In 50% of those with a known outcome, there were normal pregnancies and normal outcomes of the pregnancy. 10%, however, had fetal abnormalities, and 18 were in spontaneous abortions. In the case of dasatinib and nilotinib, again, numbers are really quite limited regards information. So in 8 females becoming pregnant whilst taking dasatinib, 3 had an induced abortion, 2 spontaneous abortions, and the other 3 were normal outcomes of pregnancy. So advice to give: TKIs we know inhibit growth factors and proteins involved in fetal development, so avoid conception whilst taking TKI therapy, and of course speak to the hospital. CML and pregnancy. CML can occur during pregnancy. So in the first trimester, management tends to be leukapheresis with or without use of aspirin or low molecular weight heparin. In the second and third trimesters, if leukapheresis is not tolerated or it's ineffective, there's the possibility for using interferon, and this is said to be probably safe, avoid if possible. If, however, we've got a case of CML and the mother is in treatment and the woman becomes pregnant, we obviously have to think about the risks to the mother with also versus the risk to the fetus. So we think about wishes of the parents, what the current disease response is, and other therapies that may be possible to use. Options may include termination of the pregnancy. It may also include close monitoring of the pregnancy and consideration of termination in case of abnormalities. In terms of, I just wanted to put this in as well, in terms of breastfeeding, there are reports of imatinib in breast milk, so breastfeeding should be strongly discouraged. What about women with CML and having this planned pregnancy? So we've heard about STOP, taking a break from TKIs. Unfortunately, there is no standard response for women, and data at the moment is insufficient to make recommendations about treatment discontinuation. Now, this is a paper by Appley in 2009, who actually gave some optimizing management of some guidelines for female patients who are planning a pregnancy. So the idea about preconception was ideally women are 24 months in major molecular response before discontinuing imatinib. There needs to be counselling about the risks to the infant of imatinib and also the risks to the mother of stopping treatment. There needed to be limited attempts at conception. So this was a period of stopping imatinib to becoming pregnant of less than 6 months. Obviously, the drug needed to be stopped before trying to conceive, and there's a suggested washout period, and this really varies. They suggested 7 days. I know that in other centres this is 8 days, 10 days, 14 days. With regards to disease monitoring, again, this needs to be done very closely. So monthly monitoring, and there needs to be a plan of action if there is a loss of response as to how that's actually going to be dealt with. So what advice do we give? Check with the hospital, because management really in this situation is completely personalised. Can and should TKIs be stopped will depend on an individual patient's case. There needs to be monthly monitoring, and that needs to be done, strictly and closely. And there's a possibility of use of interferon, but again, this needs to be something that's discussed with a medical team before patients go into thinking about having a planned pregnancy. So in conclusion, our knowledge about sex, sexuality and self-esteem in CML is really limited. These are real issues for patients, and reading through the literature, these are not all of I've heard other comments here whilst I've been here about menopause, etc. These are things that are not highlighted in the literature. So I think one of the things is really important about patients groups, and I'll come back to this. What can patient groups do? So provide support to patients and carers, provide up-to-date information, so things like newsletters, education days, good quality information. Encourage the patient voice, encourage information, experience and sharing, and find out what patients want. And I think this is really important with research. There's so many people out there who've got so many questions. I think it's really important that we tap into that and help us as healthcare professionals to provide an appropriate care for CML patients. Thanks for your attention.
Sarah, thank you very much for that interesting presentation. Well, since we actually ran out of time, maybe we just allow one question if there is.
Can I have one question
on
the sexual life? Are there any scientific study out there targeting specifically at how CML as a disease or the TKI therapy, the side effect of these therapies affect or influence our sexual lives, both biologically and psychologically? For example, on the biological front, will our sex drive be affected?
I can't see who's actually speaking. I want to just direct. Okay. No, is the short answer, unfortunately. I've heard of some studies which there are some plans to put in quality of life. This is to do with TKIs and stopping drugs. So there are plans to evaluate quality of life, and I'm sure that some aspects of sexuality and sexual functioning will be reported within that, but specifically looking at biological, psychological aspects about sexuality. No, I'm not aware of that, so unfortunately.
The study, there's no such study, or there is no such evidence?
I don't believe that there's any particular focus study on that. I think there tends to be studies, and we tend to do add-ons about quality of life, which is useful. But the focus is quality of life. The focus isn't specifically using measures for sexual health, for psychological indices. So the answers that you get are very much focused on quality of life.
But sexual life is a part of the quality of life issue, right?
It is, yeah. But the instruments don't tend to be quite so focused on sexual issues.
So actually, if my observation is correct, I think the medical community is shying away from this issue, right?
Yeah.